Good afternoon, everyone. Thank you so much for the organizing committee for inviting me for this discussion. So I practice in Vancouver in Canada, and we've been using a lot of pharmacotherapy for management of obesity. I do run one of the biggest multidisciplinary clinics in Canada for obesity management, and I'd be pleased to share with you some of the details from the landmark semaglutide 2.4 milligram Wegovy trials, and also I'll share with you my own clinical experience, from a real world perspective. So we'll talk about the key step studies. These are my disclosures that you see on the screen here. I'm quite involved in clinical trials and research as well, and I am getting an honorarium from Novo Nordisk India for presentation. Having said this, I had complete editorial control over the slides that I'm going to share with you, and everything is appropriately referenced. So if there's only one thing that you could take away from my talk today, it would be that understanding that obesity is very complex and multifactorial. The next time a patient comes to your clinic and says, "Doctor, why am I having obesity? I don't even eat that much." The things are that it is so complex and multifactorial that it's very difficult to delineate one particular reason why an individual is suffering from obesity. All of us, at a very brainstem level perspective, the idea is that we're always trying to preserve a certain body weight. But if that thermostat or if the regulator in the body gets affected, then it becomes a difficult task for us to maintain that particular body weight. And then we tend to have ongoing increase in the body weight. So it's probably an amalgamation of genetic predisposition as well as multiple comorbidities that person could be having, as well as the psychosocial and environmental aspects that we are currently subjected to. Highly processed foods, lack of exercise, sedentary behavior, all of these things can contribute. But if you had to ask me one particular part of the body that is involved with weight regulation, it's not the gut, it's actually the brain. And within the brain, there are three different parts of the brain that are very closely intertwined when it comes to the regulation of body weight. So we'll look at each of these three things. The first one is homeostatic eating. So this is occurring at the level of the hypothalamus, where we are trying to have a certain body weight that we are trying to maintain. So that's the homeostatic eating part. Then we have hedonic eating, which is when we eat a certain food, the pleasure that we derive, the feelings that get generated when we have our favorite food item, that's coming from the hedonic part of the brain. And then in the prefrontal cortex, we have the executive functioning part, which helps to determine what we eat, how much we eat, so things like that. So if I had to give some practical examples from the homeostatic eating perspective, all of us, in our body, there's this very fine yin and yang that is going on, this fine balance. So we have orexogenic hormones, so hormones like ghrelin, which will cause more hunger. And then we have anorexogenic hormones. So these are hormones like leptin, GLP, PYY. These will help with satiation and prevention of hunger. So if you have ever heard the term hangry, right? When you get hungry and it starts affecting your emotions, that's essentially related to the hormone ghrelin. And it's very important because from a caveman perspective, the whole idea was for self-preservation, it is important that we feel hunger. Because if we don't feel hungry, then we won't eat. And that will obviously be detrimental to self-preservation. So that's at a very caveman level, the homeostatic part of our brain, which helps with regulating of body weight. Then comes the hedonic part. This is what differentiates humans from other species as well. So at the end of a long day in clinic, when I'm heading back home and I'm very hungry because I probably had only a little breakfast, and then clinic, I'm seeing patients all day long, probably didn't have enough time for lunch. So as I'm approaching home, I now start thinking about food and the hunger that's in my body. And then I start thinking that I'm craving my favorite item. So I really love Belgian dark chocolate ice cream. That's my one guilty pleasure. So when I'm starting to drive back home, I think about that tub of Belgian dark chocolate ice cream in my freezer. And obviously, when the hunger is high, the body wants maximum impact with minimal effort. So we always crave for high calorie dense foods. So when I actually reach home and open the refrigerator, I could go and take a look at the hummus or some healthy snacks that I have, but instead I open the freezer and I go for the Belgian dark chocolate ice cream. That is derived from the cannabinoid receptors and the dopaminergic pathway, because as soon as I have that first bite of that Belgian dark chocolate ice cream, that's when I really feel that, okay, this is the pleasure sensation. Nutritionally, I probably don't need that, but I'm still having that. And that's what's driving that pleasure, the liking of food that's coming from this particular pathway. And then finally, when you look at the cognitive aspect, you look at the prefrontal cortex. So all of us, we just had lunch at a buffet here. So when you first took the plate, whether you go to the salad counter, whether you go to the soup counter, or whether you go directly to the mains, that is determined by the prefrontal cortex. The amount of servings that we take, that is determined by the prefrontal cortex. So when you're looking at an individual with obesity, it's very important to understand that you look at these different parts of their history, trying to look at their cravings, trying to look at what food choices that they're making in order to understand what is at a very cardinal level. Why is it that these individuals make the choices that they are making, and what is leading to these different aspects that goes with weight regulation? Now, it's very easy for us or any healthcare professional to say, you should eat less and move more. But that will never work for obesity management, because it is not a problem of willpower. It is not that individuals are lazy and they're not affected or they're not interested about their own health. The problem is that when we focus only on lifestyle interventions, then these are bound to fail, because a lot of times, all of us in this room, either we ourselves or we know someone that has gone on a crash diet in order to lose some weight. And crash diets will work, but only for a short period of time. So with all these lifestyle interventions, there will be weight loss, but the story you can replicate, copy paste with every patient that comes in your clinic. They'll be like, a few years ago, I decided that I would want to lose weight. I lost 10 kilos, but gained all of it back. The problem is because these measures are not sustainable. If somebody were to ask me what is the best diet, I would say the diet that you see yourself eating for the rest of your life. If it is sustainable, that will have the maximum impact and the maximum benefit. So the problem is, if we focus too much on diets that are not really sustainable, then failure is bound to happen. Also, in order for us to understand why diets are failing, it's important to understand that self-preservation again. So what you see on the left-hand side here is basically an individual trying to lose weight. So when we're trying to lose weight, we'll try to reduce our caloric intake. We'll try to increase our physical activity. But because we are built for self-preservation, as soon as we start losing weight, paradoxically, the hunger hormones, the ghrelin levels will start going up. We start reducing our anorexogenic hormones. We'll start having reduction of our fullness hormones. So GLP-1, leptin, all these hormone levels will go down, and our basal metabolic rate will also go down. So the problem is, even though we are trying to lose weight, our body does not like that, and it tries to pull it back. So we often think about it. When I talk to my patients, I tell them that when you try to lose weight, it's like stretching a rubber band. So the more weight you try to lose and more efforts you put in, you're stretching out that rubber band. But the minute you let that rubber band go, it's going to snap back, because the body wants to go back to that previous regulator, the previous thermostat that it was set at. So the whole idea is that, unfortunately, these measures will not sustain in the long run because the body wants to pull it back. Now, we understand that weight loss is important. We don't care about the aesthetic aspect. Obviously, individuals living with obesity, that could be an important aspect for them. But as healthcare professionals, we understand that even a little goes a long way. We know that any amount of weight loss, the more there's weight loss, the more profound effects it can have on metabolic parameters, mechanical parameters, and it helps to improve the overall health of an individual. And nothing is more gratifying than to see an individual that loses weight who's able to come off their medications for diabetes or for their blood pressure, and then they get even that more ongoing drive that they want to try even harder and come off some more medications or potentially reduce more medications. So from that perspective, we understand that lifestyle interventions may not be helpful on their own, and hence we need more help in managing individuals living with obesity. This is where pharmacotherapy can have an immense role to play. So we'll talk a little bit more about the Wegovy 2.4 milligram or semaglutide 2.4 milligram. And the idea is that this particular medication will work on the homeostatic effect part of the brain. So the hypothalamus, where we have the POMC nucleus that regulates our hunger, that regulates our satiety, feeling full, understanding how long do we go on for before we have our next meal. All of that is regulated by this medication. It also helps to reduce the craving. So if I am on this medication, I'll be less likely to think about that Belgian dark chocolate ice cream, so that, if I don't crave for that, I'll be less likely to have these calorie-dense foods. So understanding the mechanism of action is very important. It is a GLP-1 hormone, so we've all been accustomed to the GLP-1 effect in type 2 diabetes, but this medication for the weight loss aspect works in people with or even without type 2 diabetes because it is independent of that glucose regulating aspect. The idea is that this will help people feel full for a longer period of time, so that the food noise that is in the brain, the constant chatter when people think about food and hence they have to act upon it, that will go down. People will no longer constantly think about food. At the same time, when they do have food, the cravings will be lower, and that helps to go at the root of the problem and giving them that extra help that their body needs in order to lose that excess adiposity. Now, semaglutide 2.4 milligrams or Wegovy has been studied in a whole different slew of different clinical aspects. So whether you look at just obesity on its own, or people with obesity and type 2 diabetes, or those with osteoarthritis, those with sleep apnea, those with pre-diabetes, you name the condition with comorbidity, and chances are that there is a STEP study or a semaglutide 2.4 milligram study that has looked exactly at that particular type of patient. And we've had experience over hundreds of thousands of people that were in the trial, as well, of course, as millions of people that are using this medication on a clinical perspective. Interestingly, India has been a very strong aspect of all the clinical trials. There's been tons of these clinical trials that have been done with Wegovy, and some of the trialists might be here in the audience as well. So I'm going to share with you two different trials that I feel are the key aspects of Wegovy. So we'll talk about the STEP 1 study. STEP 1 study essentially looked at people with overweight or obesity, with or without comorbidities, but without type 2 diabetes. And they were randomized into either standard of care with placebo, or they were stepped up to the Wegovy 2.4 milligram dose. And they were kept on this medication for over a year, trying to see what the degree of weight loss is. And what was seen was that compared to placebo, patients on Wegovy did profoundly better. So placebo patients were still getting lifestyle interventions, so it was not just pure placebo only. And with that, they had a 2.4% weight reduction, which is what we see in many of the lifestyle intervention studies. But with adding Wegovy on top of that lifestyle intervention, there is a staggering 16.9% weight reduction. And if you see from these graphs, you'll see that at the time of that end of that study over a year, it is not having a weight regain. So that's very important. Also, it's important to note that the sheer efficacy and the applicability of these medications, because you'll see that on semaglutide 2.4 milligrams, more than 90% of people will lose at least 5% of body weight, which is very important because that's the minimum target that we aim for improving metabolic parameters. So we know that at least 90% of these individuals will lose at least 5% of their body weight. And what's very important to see, before Wegovy 2.4 milligram came out, we hadn't seen such results with any other pharmacotherapy, where we now see over a third of people will lose even more than 20% body weight, which is obviously very significant from a pharmacotherapy perspective. There were a lot of secondary endpoints as well. So weight is one thing, but when that weight translates to reduction of waist circumference, we know that we are reducing visceral adiposity. We are improving cardiovascular parameters like blood pressure. Patient quality of life improves. We know that A1C also goes down. Now, this was in a group of people without diabetes, and A1C dropped by 0.5%. And of course, we know that semaglutide does not cause hypoglycemia. So there's that built-in safety switch associated with the medication. Now, one question that we often get is, how long will a patient need to be on the medication for? So if there's only one other thing that you could take away from my talk today, it would be that obesity is a chronic disease. Just like when we manage hypertension or diabetes, once we initiate a patient on medication, and if they do well, we continue that medication because the body needs that as part of any chronic disease. And this was exemplified in the STEP 4 study. So in the step 4 study, what they did was they looked at people with obesity, and they initiated all of these individuals on Wegovy 2.4 milligram in a stepwise up titration. And at the end of 20 weeks, these people were then divided into two groups. One group continued to get Wegovy 2.4 milligrams. The other group then started getting placebo injections, and then they were followed for over 1 year. And this is what the results show. So at that 20-week mark, up until 20 weeks, everyone was getting Wegovy, and you'll see that there is a profound degree of weight loss that's happening. But when people stop taking that, there is weight regain that happens. So at the end of that 1 year, if you look at the placebo group, based on their baseline weight versus their end weight, it was 6.9% difference. Versus those people that continue to get Wegovy, you'll see that ongoing decline in their body weight. And you'll see that that is 18.2% body weight reduction compared to baseline. So this is very important to see, because more than 1 out of 3 people will lose at least 20% of their body weight. Step 5 is a maintenance trial. So again, we are trying to see what happens ongoing in these individuals. And this is a long-term study. So far, I've shown you 68-week studies. What about long-term? So that's what the question step 5 addresses, because this is a study that went over 2 years. So 104 weeks, and even at 104 weeks, you'll see that we are maintaining the plateau. So there's still the weight loss that has happened continues to go on. There's no rebound, because that's one of the biggest challenges. When people start failing pharmacotherapy, there's weight rebound, whereas this is still keeping that weight down, and that continues even at the end of 2 years. I know our next speaker will also talk about the SELECT study from a cardiovascular perspective, but from a weight perspective, the SELECT study was, again, a very long-term study. So it was 4 years total duration. And same story that we are seeing over here. The weight loss happens on an ongoing basis, and once it reaches that mark at about a year or so, that weight loss continues even as long as 4 years. Now, from a side effect profile, with any incretin therapy, the commonest side effect is gastrointestinal side effects. So nausea can be the commonest side effect, but it's important to note that the nausea is self-limited, and it is mild and transient for majority of individuals. In fact, a very low number of people had adverse events that led to discontinuation of the medication. So if I had to summarize everything that we have discussed so far, the idea is that Wegovy 2.4 milligrams is an approved pharmacotherapy across the world, where we are seeing a profound degree of weight loss in a healthy manner that is associated with improved outcomes and has much better weight loss than any of the previous medications prior to Wegovy. We are seeing more than 20% weight loss in over 33% of individuals, and this continues ongoing. So it's not a short-term effect. This is long-term sustenance of the weight loss. And with that comes a slew of improvements in cardiovascular factors that some of our other speakers will talk about today as well. With that, I'd like to thank you for your time and attention, and I'll hand it back to our chairs.